And thank you so much to the Lymphoma Research Foundation for this invitation to speak with all of you about immunotherapy beyond CAR T-cell therapy. So moving forward, just a little bit of background. Tools for treating lymphoma historically have been based on the age-old concept of killing cancer cells with chemotherapy or radiation treatment. As you very well know, chemotherapy and radiation is not specific. As a result, the fastest growing cells are destroyed with these two approaches, and that would mean the cancer cells, but at the cost of other normal, fast-growing cells. As a result, healthy cells also get affected, and therefore patients can have side effects from these treatments. In terms of the new tools that we have to treat lymphomas, it's immunotherapy. Immunotherapy really unleashes the potential of the patient's own immune system. To put it simply, usually everybody gets exposed to antigens that are foreign every day. And this is when the patient's own fighter cells are able to look at this antigen as foreign, recognize, and then destroy it. In patients who develop cancers, especially lymphomas, these fighter cells are not able to recognize these foreign antigens as an enemy. As a result, cancer cells thrive. Therefore, in terms of treating lymphomas with this new tool called immunotherapy, you can technically use the patient's own immune system, which is weak, but make it stronger with many, many medications, and then use the same immune system to kill the cancer cell. The idea is to only treat the cancer cell and thus spares the normal cells. As a result, over the last 3 decades, there have been substantial advances within the field of lymphoma, and that has made it to the top-tier journals within science. In terms of the immunity that we use to manipulate and fight off cancer cells, there are 2 distinct types of immunity that we are all born with. The first is innate immunity. Innate immunity pretty much kicks off whenever a foreign antigen is exposed to the body within a few hours of exposure. Innate immunity cells comprise of natural killer cells, NK cells, phagocytes like macrophages, and then there is the adaptive immunity. Adaptive immunity cells are the cells that get exposed and triggered after a few days of exposure to the foreign antigen. Adaptive immunity primarily can comprise of B cells, B lymphocytes, plasma cells, or T cells. And so far, most of the immune therapies that have been successfully utilized have so far successfully utilized the adaptive immunity, which is making the patient's own T cells stronger and be able to fight off cancer. So in terms of what all has happened over the last 3.5 decades, there have been a lot of clinical trials. And then finally, after nearly 3 decades of work, in 2020 and moving forward, we finally have had a slew of options with regards to immunotherapy and its efficacy and help to treat lymphomas. CAR T-cell therapy, of course, is the front runner, and I'm sure you have attended other CAR T-cell therapy sessions on this program. So my task is really to talk about other immune approaches that have also been successfully used over the last few decades. But before I really deep dive into it, it's important to really quickly go over, and I'm very, very certain my other colleagues have done a fantastic job of going over this, but to put everything into context, as you all know, lymphoma is not one disease. It's made up of nearly 85 different types. And therefore, to put it simply, I like simple, and I use this algorithm a lot in my clinic to tell my patients what they have. Lymphomas are primarily divided into Hodgkin or non-Hodgkin lymphoma. Non-Hodgkin lymphoma is further divided into the more common, meaning 85% of non-Hodgkin would comprise of B-cell non-Hodgkin lymphomas, and then 10 to 15% would comprise of T-cell or natural killer cell non-Hodgkin lymphoma. B-cell non-Hodgkin lymphomas are further divided into nearly 45 to 50 different types, but to put it simply, it's divided into 3 buckets. The first bucket is aggressive lymphoma. Patients have a fast-growing disease. They have a lot of symptoms. As a result, usually chemotherapy has been the backbone of treatment for patients with aggressive lymphoma, like diffuse large cell lymphoma. Also, we're going to be mentioned in this PowerPoint as DLBCL, Burkitt lymphoma, mediastinal lymphoma. These are aggressive lymphomas. Chemotherapy with Rituxan, which is actually immunotherapy. So chemoimmunotherapy has the ability to cure quite a sizable number of patients, but in patients who relapse, there have been multiple clinical trials which have yielded fruit, and I will go through some of those therapies as well. Indolent lymphomas or slow-growing lymphomas are chronic lymphomas. These are slow, chronic diseases. Sometimes patients are recommended watch and wait, but when treatment is necessary, treatment could mean either radiation or antibody treatment, or sometimes even tablets, which are completely chemo-free. And then there is the third bucket, which is a mixed lymphoma, where patients can initially start off having a non-aggressive biology and then pick up and become an aggressive lymphoma. Poster children of mixed lymphomas would be mantle cell lymphoma or transform lymphomas. So I just wanted to give you a quick snapshot, since I will be talking about a lot of lymphomas, as my topic for today is going to be immunotherapy, and thus I'm going to mention a lot of these subtypes. So what am I going to really cover today? Clearly not CAR T-cell therapy, but beyond CAR T-cell therapy. So beyond CAR T-cell therapy, I do have to say we have been using immunotherapy in lymphomas for nearly 3 decades already. And to start off, we have monoclonal antibodies. And then most recently, over the last 4 to 5 years, there have been a slew of other agents like antibody drug conjugates, checkpoint blockade, immunomodulators, and bispecific antibody T-cell engagers called BiTEs. So moving forward, I'm going to go through one of these every few minutes so as to help you understand where have they been implemented and approved, and how have they been actually helping us to move the needle forward in patients with lymphoma. So in terms of understanding monoclonal antibodies, we need to understand that B cell, which is what we are all born with, have a recognition receptor called a cluster of differentiation marker, or CD marker, on its surface. These CD markers actually help us in the diagnosis of lymphomas. It helps us really understand what type of lymphoma does a patient have. For example, patients who have B-cell lymphomas, they usually have CD20 that is positive on the stain under the microscope. In terms of other B-cell lymphomas like follicular lymphoma, they will have a CD20 and a CD10 that is positive. In terms of mantle cell lymphoma, they will have a CD20 and a CD5 positive. So you get the gist that CD markers aid in differentiation, but it also aids in helping us develop tools to attack these receptors and thus destroy lymphoma cells, specifically certain subtypes of lymphoma cells that sit on these B cells. So monoclonal antibodies are basically, they look like what the diagram shows on the right of this PowerPoint. And as you can see, a monoclonal antibody has a light chain and it has a heavy chain. On the light and heavy chain here is what we call the antigen binding site. So you can imagine that we can technically manufacture a monoclonal antibody against any antigen. The first one to really help us move the needle is Rituxan or rituximab. Rituximab is a monoclonal antibody that is directed against a protein on the B cell called CD20. And when this antibody binds to the lymphoma molecule containing CD20, it unleashes its mechanism of action, which is it either directly kills the lymphoma cell, or it activates an immune system called the complement system, or it also activates the innate immunity, which I talked about, which consists of the macrophages and causes lysis or destruction of cells. In terms of monoclonal antibodies that have been approved over several years for patients with B-cell lymphomas, we have rituximab. Rituximab is the backbone for therapy with aggressive B-cell non-Hodgkin lymphoma, like Burkitt lymphoma, diffuse large B-cell lymphoma. You may have heard of chemotherapies like R-CHOP, R-EPOCH. It's basically chemoimmunotherapy because the chemotherapy backbone is the CHOP, the immunotherapy is Rituxan. And rituximab improved survival for patients with diffuse large B-cell lymphoma when combined with CHOP. As a result, anybody who has an aggressive B-cell non-Hodgkin lymphoma, usually the backbone of the immunotherapy is always rituximab. There are also several other newer anti-CD20 targets that have developed, for example, ofatumumab, ublituximab, but the one to make it to FDA approval is obinutuzumab, also called Gazyva. Obinutuzumab is slightly more potent rituximab. It binds to the same protein. It may have slightly higher infusion reactions, but nonetheless very manageable. Obinutuzumab is currently approved for patients with CLL and follicular lymphoma. In terms of other monoclonal antibodies that have recently gotten approval is a monoclonal antibody called tafasitamab. Tafasitamab is an antibody that sits on the protein of the B cell that expresses CD19. So it's an anti-CD19 antibody. Tafasitamab makes the cell lysis happen exactly pretty much similar to rituximab, meaning with the direct cell death, with activation of the innate system or the complement activation. It is currently approved in patients with relapsed refractory diffuse large B-cell lymphoma in combination with an immunomodulator, which I will come to in the next few slides. So talking a little bit more about antibody treatment, I did allude to the fact that for therapy for aggressive B-cell non-Hodgkin lymphomas, we absolutely have to use chemotherapy in combination with Rituxan or rituximab. That improves patient survival. There have been multiple attempts to improve upon survival by changing the chemotherapy backbone, which I will talk to in the next few slides. In patients with the low-grade indolent lymphomas, initial therapy can be with either single-agent rituximab that's given every week for 4 times or every week for 6 times. For example, in patients with follicular or marginal zone lymphoma, or in patients with CLL, antibody treatment with Gazyva or obinutuzumab with venetoclax, which is a chemo-free pill, is now approved for frontline treatment for CLL. There is a concept called maintenance therapy that is used with this antibody approach for a lot of low-grade indolent lymphomas. Once a patient attains a remission, we want to see what could be done to improve and maintain and increase the ability to stay in remission. This is where maintenance therapy has come into play. And with regards to maintenance therapy, antibody treatment after completion of a successful treatment is given every 2 months for maybe a couple of years, every 2 months for 3 years, and it's currently offered to patients with follicular lymphoma, marginal zone lymphoma, and mantle cell lymphoma. Antibody maintenance treatment is not something that is recommended based on clinical trial data for patients with aggressive lymphomas like diffuse large cell lymphoma. So moving on to the next immunotherapy agent is antibody drug conjugate. So we clearly know that antibodies can bind to proteins on the lymphoma cell and cause cell death. Antibody drug conjugates, or ADCs, are basically empowered antibodies, is what I like to call it. Because this antibody not only sits and latches onto the lymphoma cell, but through a special linker is able to release a toxin, chemotherapy, into the cancer cell and basically not affect normal cells. Usually the way that's done is antibody drug conjugates are developed against certain proteins. So it could be CD30, it could be CD79, and I'll talk to you about these agents in a little bit. But basically ADCs, once they bind to a lymphoma cell expressing that protein, they get internalized into the lymphoma cell. They release the chemotherapy just to the lymphoma cell and kill it. As a result, usually they spare the normal cells of side effects. The first antibody drug conjugate to really make a big splash in the management of lymphomas, both B-cell lymphomas as well as T-cell lymphomas and Hodgkin lymphomas, has been brentuximab, also called Adcetris. Brentuximab sits on a lymphoma cell that expresses CD30. CD30 is expressed on Hodgkin cells as well as T-cell lymphomas. So you can imagine that you can use this agent in a lot of these subtypes of lymphomas. So brentuximab mechanism of action is that the antibody sits on the CD30 protein, it gets internalized, and then it initiates cell destruction of this specific lymphoma cell. The way Adcetris has been previously utilized is in Hodgkin lymphoma and T-cell lymphomas because these two subtypes express CD30 a lot. So in patients with relapsed Hodgkin lymphoma, previously there was not a lot of options beyond chemotherapy and autotransplant. Brentuximab showed that nearly 73% of patients had a response, meaning the lymphoma shrunk 73% of times after exposure to brentuximab in heavily pretreated patients with Hodgkin lymphoma. Similarly, there was also benefit seen in patients with T-cell non-Hodgkin lymphoma, meaning anaplastic large cell lymphoma and also other subtypes of T-cell non-Hodgkin lymphoma. Based on that, Echelon 1 is a trial that was designed to compete the age-old standard in Hodgkin lymphoma, which has been ABVD. ABVD consists of a chemotherapy called bleomycin, which has the potential to cause lung toxicity. So in order to make sure that patients don't have the lung toxicity, and also to see if they can improve upon survival, improve upon the ability to stay in remission, we had to keep going, discovering newer agents. And based on that, about 1,300 patients were randomly assigned to either getting the standard, which is ABVD times 6, or A plus AVD, A meaning brentuximab plus AVD, substituting the B of bleomycin for 6 cycles. And then they followed these patients. What they did see was a striking benefit in favor of AAVD, wherein patients did not have lung toxicity, as was seen with patients who received ABVD. In addition to that, there was a 23% reduction in risk of progression, death, or the need to have more treatments in the future. And the most recent update of this Echelon 1 study is that the patients who received AAVD eventually also ended up having a longer survival. As a result, at this time, we no longer would offer ABVD to patients with stage 3 or stage 4 Hodgkin lymphoma, and usually we typically offer AAVD. Now, I also want to say that brentuximab can have side effects. Although not pulmonary toxicity or lung toxicity, brentuximab can cause what we call neuropathies, or pins and needles and feeling of numbness of the hands or feet. It can make the neutrophil count or the white count go down. So the physician really has to make sure that the communication is ongoing. Make sure that if you do experience neuropathy, to bring it up to your physician so that we can dose reduce the brentuximab in order to retain efficacy, but also not to make you exposed to over toxicity. Moving forward to the other antibody drug conjugate that also made huge headways in patients with relapsed aggressive lymphomas. I alluded to in the past that patients with aggressive lymphoma have a potential for a cure, at least 50% of the times with upfront chemotherapy. But for the remaining 50%, previously there was not a lot of options. Now we do, including CAR T-cell therapy. But before CAR T-cell therapy made a big splash, there was polatuzumab. Polatuzumab is an antibody drug conjugate that sits on a protein, CD79B, that's expressed on B cells, and it then causes lymphoma cell death. This clinical trial compared chemotherapy to polatuzumab and chemotherapy. in relapsed refractory follicular and diffuse large cell lymphomas. You can see on these curves that the blue line is on top over the red line on both sides, which was the blue line contained patients who received polatuzumab plus chemotherapy. So clearly it had a huge improvement in keeping patients in remission, but also improving survival for those patients who had relapsed refractory large cell lymphoma. And based on that, the FDA approved polatuzumab for patients with relapsed refractory diffuse large cell lymphoma. In terms of how we move the needle in patients with lymphoma management, we really want to make sure that we keep improving. Our goal is to cure 100% of patients upfront. And with that in mind, R-CHOP, although has been the standard of care for nearly over 20 years, there have been multiple efforts to improve upon R-CHOP. There were efforts to increase the frequency of it, to make sure we can add one more chemotherapy and compare it with R-CHOP. But no matter what we did, there was absolutely no benefit to R-CHOP versus the experimental agent. As a result, R-CHOP was the standard of care for nearly 2 decades, until the POLARIX study was presented last year by investigators who were testing R-CHOP versus R-CHP plus POLA, wherein the O of CHOP was replaced by polatuzumab. And for the first time, there was a benefit in patients to keep them in remission longer at the follow-up period of nearly 2.5 years, where with POLA-R-CHP, the 2-year progression-free survival was 77% with POLA-R-CHP versus 70% with R-CHOP. Now, we are eagerly awaiting FDA decision to see if this could be the new standard of care for patients with advanced stage, high risk, untreated, newly diagnosed diffuse large B-cell lymphoma. Just like with brentuximab, polatuzumab can also cause neuropathy. As a result, if patients develop it early on, make sure you bring it up to your physician so as to make sure that they can appropriately dose adjust polatuzumab. In terms of the most recent antibody drug conjugate that also has shown to be a huge help in making sure that the improvement in DLBCL relapse patients continues is loncastuximab, also called Lonca-T. Lonca-T is also an antibody drug conjugate, and in this study, in heavily pretreated relapsed refractory large cell lymphoma patients, the overall response rate was nearly 50%. So 50% of patients who never had any options had a great response with this drug. In terms of side effects, side effect profile of Lonca-T is actually very, very manageable. Patients don't really have a lot of nausea. They don't have a lot of diarrhea, but they can experience swelling of the feet. They can experience some effusions of fluid buildup around the lungs. As a result, if patients develop edema of the feet or swelling of the feet or shortness of breath, make sure they bring it up to their physicians. It is a reversible side effect. In terms of my experience with Lonca-T, there have been many times that not everybody can go to CAR T-cell therapy. And in my patients with relapsed refractory diffuse large cell lymphoma, Lonca-T has actually helped these patients continue to be in remission for a long period of time. So based on that, the FDA granted approval for Lonca-T in patients who have been exposed to 2 or more prior lines of treatment with relapsed refractory aggressive large cell lymphoma. Moving forward, checkpoint blockade. Checkpoint blockade truly is the true utilization of our own immune system. So in terms of how our immunity works, anytime we have an antigen, our fighter cells recognize it and they mount a response, and that's how the antigen gets killed. But at some point, you have to stop that fighter cell from killing it. Otherwise, it may start killing the normal cells. And that's where checkpoints are currently present, which basically checkpoint or block the T cells and say your work is done, now hush. As a result, checkpoints can either act as an accelerator or a break. So you can imagine that we could potentially use it to develop tools so that the T cell activation or the fighter cell activation is kept on. This is basically a quick diagram of how a tumor cell makes your own fighter cells redundant. So whenever a tumor cell proliferates, the reason it proliferates is because the T cell is not able to mount a response because there are changes on the checkpoints that happen on the T cells, as a result of which they either just get completely exhausted or they don't recognize tumor cells as foreign. As a result, we can typically utilize and manufacture molecules or agents that can either inhibit the inhibitory checkpoints and thus keep the T cell activation on, or we can potentially stimulate the stimulatory checkpoints and keep it on as well. So moving forward, in terms of which checkpoint inhibitors have clearly made a huge impact in lymphomas, it's been PD-1 inhibitors. So PD-1 is basically a receptor that's present on the tumor, on the T cell here, right here on the blue, and it has a receptor called PD-L1, which is expressed on the tumor cells. Usually, anytime the PD-1 molecule binds to PD-L1, it makes the T cell inhibit and not function. Therefore, if we develop an antibody that sits on the PD-1 and break this bond, the T cell could technically stay activated and kill the tumor cells. That's really the mechanism of action of patients who get Pembrolizumab or Nivolumab, which are PD-1 antibodies. This is called a waterfall plot. The waterfall plot basically represents a bar. Each patient is a bar, and anytime you have bars that go downward, that means a patient responded to the drug. This is a cracker of a molecule because this basically represents nearly 80% of patients who had response to Nivolumab, which is a PD-1 inhibitor, if they had relapsed Hodgkin lymphoma. So clearly this drug works. But remember, Nivolumab or Pembrolizumab, the mechanism of action is to activate your T cells and to make them fighter cells and kill off the cancer cell. They do it really well. But you obviously have to make sure that some side effects that can happen with Nivolumab is brought to medical attention, and the physician also keenly looks over it. Some of the side effects that can happen is because of excessive T cell activation, because sometimes that can translate into inflammation of certain areas of the body. For example, it can cause a rash because it can cause inflammation of the skin. It can cause diarrhea because it can cause inflammation of the gut. It can make someone have shortness of breath because it can cause inflammation of the lungs. So these are some of the things, albeit thankfully very, very rare, that can happen with these molecules. What doesn't usually happen is chemo-related side effects. So you don't typically see hair loss. You don't typically see a lot of nausea. You don't typically see chemo-related side effects like drop in counts. As a result, a lot of times when patients receive these products, these patients don't experience a lot of side effects. They have a great quality of life with agents like PD-1 inhibition. This is one of my patients who had relapsed Hodgkin lymphoma. He received Nivolumab, and after that, as you can see on the right, on the PET scan, all of these multiple FDG-avid lesions, which are metabolically active and black on a PET scan, have completely resolved. This is a clean, normal PET scan. On a normal PET scan, the heart, the tonsillar area, the kidneys, the ureters, and the bladder normally look black because these are metabolically active areas. So in terms of other successes with PD-1 inhibitors, this is one of my other patients who had a large mass in his mediastinum, which is the space between the lungs. In this large mass, he received 3 cycles of Pembrolizumab, and you can see that at this point, the mass has actually shrunk. It's still there, but it's shrunk to nearly 80% of its original size, and the patient is doing exceedingly well. The big question is, when can we stop PD-1 inhibitors. On the clinical trial, it was given for about 2 years. There had been patients who came off of it in response, and these patients continue to be in response. There are times that patients may relapse after stopping the agent, at which time we usually retreat the patient with the same agent. Given the excellent success of nivolumab in patients with relapse Hodgkin, the next intuitive thing is to bring it up front and to see if our lofty goal of 100% can be achieved in patients with newly diagnosed Hodgkin lymphoma. And thus was born this SWOG study, which is an intergroup NCI-sponsored study in patients with advanced stage Hodgkin lymphoma, where patients either get AAVD, which I have alluded to is the new standard of care for patients with advanced stage, meaning stage 3 or 4 Hodgkin lymphoma, or nivolumab plus AVD. The clinical trial has successfully enrolled 1,000 patients. I have personally seen patients who have been enrolled because this clinical trial is open at our site. Patients have done excellent, so we await the results to see if this may move the needle even forward, despite what we have currently in terms of successes with Hodgkin lymphoma. What are some of the other mechanisms with regards to what else could we do for patients where we can use their own immune system and destroy the lymphoma cells? Now, I do want to tell you that usually the tumor cell gets destroyed by innate immunity cells or adaptive immunity cells. Innate immunity cells, meaning macrophages, can also destroy tumor cells because macrophages recognize a signal on the tumor cell. To make it easy, let's call it an eat me signal. But tumor cells can become smart, and therefore they now start expressing proteins on it, which eventually translates into do not eat me. So anytime a macrophage comes around a tumor cell, it says, oh, it's a do not eat me signal, so let's not chew the tumor cell. That's how a tumor cell keeps growing. Now, clearly, this is our ability now to tackle the way tumor has become smarter, to become even smarter than the tumor cell. And how do we do that? We use an antibody that blocks CD47. CD47 activates that eat me signal. And if we were to block the CD47, at that point in time, the signal eventually translates to the macrophage as saying, eat me, and thus causes tumor cell death. Clearly, at this point, there is no real effect on the normal cells because these signals are prevalent on tumor cells. The one side effect that can happen with this agent is anemia. As a result, there are multiple other agents that are blocking these don't eat me signals and making the immune cells destroy the tumor cell. Some of the initial attempts with rituximab with this molecule, initially called HuF9, now called magrolimab, has shown excellent promise, as you can see on this graph here. There was a previous PET scan in patients who have had relapse refractory large cell lymphoma. You can see there's a lot of disease here. And on response at 8 weeks, so within 2 months, they had near total shrinkage of most of the cancer cells. Moving forward, what other mechanisms could we use wherein we can unleash your own immunity against lymphoma cell? And this is in the form of immunomodulators. Immunomodulators that have clearly made headlines has been one, which is lenalidomide. And there have been a slew of other agents that are currently in clinical trials. How does lenalidomide work? Lenalidomide is not chemotherapy. It basically modulates the environment around a lymphoma cell and makes it less conducive to grow. And this modulation can happen either by making your own natural killer cells work well, or your T cells work better, or the microenvironment just becomes less conducive for lymphoma cell production. As a result, lenalidomide has been used in several different lymphomas with great success. I will say that lenalidomide plus rituximab is now clinically FDA approved for patients with relapsed follicular lymphoma. This was a study that was led by Dr. John Leonard called the AUGMENT trial, wherein patients who had relapsed follicular lymphoma either received rituximab alone, which is one of the standards of care, or lenalidomide plus rituximab. And you can see on this graph, the blue curve is over the red curve, which means patients who received this combination had a better chance at staying in remission than patients who received rituximab alone. Based on that, lenalidomide plus rituximab, also called R-square, is now one of the standards of care for patients with relapsed follicular lymphoma. Clearly, if it works in the relapse setting, the next thing to do is to see if it can actually be better than chemotherapy. So a lot of patients with follicular lymphoma can sometimes be offered beyond rituximab plus chemotherapy. Usually the chemotherapy would be a chemo called bendamustine, which is less toxic. Patients don't lose hair. They don't have a lot of chemo-related side effects. But at the end of the day, it's chemotherapy. So this trial challenged the standard of rituximab plus chemo versus rituximab plus lenalidomide. Now, the good news is that there was absolutely no difference in efficacy between the two arms, which means R-square performed just as well as R-chemo. However, with R-chemo, the program is shorter. It's a 6-month program. With R-square, it's a longer program. Lenalidomide can cause some side effects. For example, it can cause muscle aches, it can cause diarrhea, it can cause skin rash. There's a very small chance it can cause a blood clot. As a result, some patients may have to start taking a baby aspirin while they are on lenalidomide. But outside of that, chemo-like side effects are usually less with lenalidomide. So it's really about patient preference at this point in terms of what they would like to do. At the same time, bendamustine rituximab is an absolutely reasonable, very efficacious regimen. So a lot of patients get offered that. Some patients could actually get a stronger rituximab backbone, which is obinutuzumab, which I talked about in that monoclonal antibody section. And some patients may be offered bendamustine plus obinutuzumab. So clearly at this point, there are many, many choices. But the good news is that on this clinical study, R-square, which is a completely chemo-free program utilizing immune therapy, is equivalent to patients who received our chemotherapy. Last but not the least, the newest kid on the block is something called a BiTE. A BiTE means a bispecific antibody T-cell engager. So how does a BiTE work? A BiTE is basically an antibody with 2 prongs. One prong sits on the tumor cell, which means it has to be directed against a protein on the tumor cell. So the BiTEs that are currently in clinical trials and may get FDA approved soon are BiTEs that are directed against CD20. And then the other prong of this antibody binds to the T cell, which is your fighter cell. And it directs the T cell to kill the tumor cell. So technically, the T cell, which has forgotten to kill tumor cell, is redirected based on this BiTE therapy to kill tumor cell. It's an infusion, or it can be given intravenously, or it can be given subcutaneously based on which BiTE we want to explore. But so far, there are at least 4 BiTEs that are way ahead in clinical trials, 3 of which may receive FDA approval fairly soon in patients with relapsed refractory diffuse large cell lymphoma or relapsed refractory follicular lymphoma. To give you a quick gestalt as to what's really going on with the overview of this bispecific therapies, these are BiTEs that have been used in patients with relapsed refractory aggressive large cell lymphoma. And you can see that in heavily pretreated lymphoma patients, the response rate was anywhere from 60 to 80% with bispecific antibody therapies. Now remember, at the end of the day, this is T cells killing the tumor cells. As a result, T cells can become activated, and they can become way too activated. So there may be a small chance of developing T cell activation syndromes like cytokine release syndrome. Very, very rarely do patients actually experience neurological toxicity. So in terms of the next question, the debate in the field has been, should we do CAR T-cell therapy or should we do bispecific antibody therapies? How should we sequence these patients? At least for now, the heartening thing to know is that after CAR T-cell therapy, there are some patients that have a relapse with large cell lymphoma. And it's important to note on this bolded panel here that in patients who relapse after CAR T-cell therapy, nearly 40% of patients responded to bispecific antibody treatments, either as a single agent or as combination. So the sequencing strategy could either be CAR T-cell therapy first, and if that does not respond, then bispecific. The advantage of bispecific treatments is that it's an off-the-shelf product. You don't have to wait for the manufacturing to happen. On the other hand, it's treatment that's given for a longer period of time. CAR T-cell therapy is something that's one and done, but it's definitely a higher upfront effort with side effects that are higher with regards to cytokine release or neurological toxicity. Just like relapse refractory DLBCL, treatments have improved and management has improved efficacy with BiTEs. There have been BiTEs that have also been explored in relapse refractory follicular lymphoma. And so far, I will say mosunetuzumab has already been approved in patients with relapse refractory follicular lymphoma in Europe. Very soon might be approved in the United States as well. It's an IV infusion. It's given for a maximum of 16 cycles. And nearly 80% of patients with relapse refractory follicular lymphoma had a response with mosunetuzumab, of which 60% had a complete response. So this is, again, time-limited treatment, very, very few side effects. Patients are able to enjoy a good quality of life. At the end of the day, we want to develop molecules that are not only efficacious, but also way less toxic, so that the quality of life for our patients is preserved. And this is certainly something that BiTEs do offer in patients with relapse refractory subtypes of lymphomas. Bispecific therapies are also being explored in the upfront setting. So they are challenging the R-CHOP, R-CHIP-POLA paradigm. So stay tuned, because clinical trials at the end of the day are continuing to move the needle to improve management in lymphomas. So in terms of an overview, so these are our tools that we have currently available in terms of utilizing our own immune treatments, our own immunity to target lymphomas. So clearly, the next step would be, do combinations work? And they do. For example, BiTE, which is mosunetuzumab, with an ADC, which is polatuzumab. So mosun plus pola has shown excellent responses in clinical trials in patients with relapse refractory large cell lymphoma as well as follicular lymphoma. The other therapy that has been FDA approved is tafasitamab plus lenalidomide. Tafasitamab, as I previously mentioned, is an anti-CD19 monoclonal antibody, and in combination with lenalidomide in patients with relapsed refractory large cell lymphoma showed that nearly 50% of patients had a complete response with this combination if they had relapse of large cell lymphoma. This is a combination that I frequently explore and do offer to my patients who are either not transplant candidates or not CAR-T candidates. This is a longer program, but the side effect profile is actually very, very manageable. FDA did grant this combination for approval in relapsed refractory large cell lymphoma after failure of one line of treatment. So in terms of the immunotherapy landscape and everything that we have talked about today, I've clearly only touched upon and given you an overview of what is in the field. I could potentially talk about each of these immunotherapy armamentarium tools for about an hour each. But having said that, you can see the ability to really improve upon treatments for lymphoma by utilizing your own immunity to target lymphoma cell. Nowhere here is really just chemotherapy. It's either targeted chemotherapy or pure immunotherapy. So clearly, I do believe that the field is evolving rapidly. Several therapeutic options with multiple agents are currently available with great promising results. And I do believe that every year my talk keeps changing in patients with relapse refractory or upfront lymphomas. And this really underscores the power of clinical trials. Your one-stop shop to understand if you are eligible for a clinical trial, where is a clinical trial happening in your region, is LRF. So make sure you do call them to see if there are ways to get to a clinical specialist who specializes in lymphomas, who offers clinical trials, exploring chemotherapy-free options. At the end of the day, we do have to harness the immune system. I do believe that clinical trials at the end of the day is our key to curing lymphomas.